Good evening, everyone. Now we'll discuss the different types of seizures that is in a newborn and different conditions that can mimic seizures in newborn. And Dr. Girish, additional professor of pediatrics working in the newborn unit, Government Medical College, Calicut. In the next 20 minutes, we will try to answer some of these questions. That is, when to call an abnormal movement a seizure. What are the challenges in identifying seizure in newborn? How important is it to identify or recognize a seizure in newborn? And what are the common seizure mimics and how to differentiate them from true seizures? We'll start off with a scenario. A term male 3.4 kilogram baby delivered via LSCS was brought to the emergency room of NICU with a history of abnormal movements noticed at 6 hours of life. Mother had history of diabetes mellitus. Baby was otherwise active. As a staff nurse working in the neonatal unit, two questions should be there. That is, should identify the abnormal movement. Is it really a seizure? Or if it is a seizure, what is the type of seizure? Because the type of seizure has got some prognostic value as well. Now, what is meant by a seizure? By definition, it's a clinical definition. They are paroxysmal alteration in the neurological function. Could be behavioral, could be motor, it could be autonomic, associated with abnormal, excessive, hypersynchronous electrical discharges from the neurons. That is the clinical definition of seizure. And seizures are not rare in newborn. In fact, newborns have the highest risk in any other period of life. Coming to the incidence, it's around 2 to 3 per thousand in full-time babies, and it's much higher in preterms. In some studies, even 22 per 100. That means almost 20% preterms can have seizures, and it also depends on the different gestational age. Now, what are the types of seizures? As per the American Clinical Neurophysiology Society, there are 3 types of seizures. One is electroclinical seizures. That means you have clinical manifestation as well as EEG correlation. Then the second type is clinical only. Here, there is no EEG manifestations, only clinical manifestations. And it is debatable. Why? Because to call a seizure, there should be some EEG changes. The third one is EEG only seizures, otherwise known as electrographic seizures. Here you have abnormal EEG, but there is no clinical correlation. These are otherwise known as subclinical seizures or occult seizures or non-convulsive seizures. So these are the 3 clinical types of seizures based on the American Clinical Neurophysiology Society classification. And what are the challenges to identify seizures in newborn? As you know, newborns can have wide variety of abnormal movements. It could be pathological, it could be physiological, and it could be seizures. And one thing you should understand is that most EEG seizures do not have clinical manifestations. So what you are seeing as seizure is only the tip of the iceberg. And most of the subtle or generalized tonic seizures will not have EEG changes. So they are not true seizures as well. You cannot theoretically call them as seizures. And another issue with the babies, especially sick babies, is that most of the babies will be on ventilator care. And these babies will be on anticonvulsants. And these sedation and anticonvulsants can suppress the clinical manifestation of a seizure. And in fact, the baby will be seizing. Like they have electrical seizures, but there will not be any clinical correlation, clinical manifestations. That also can add to the injury. brain injury. And in one study, when pre-recorded events were shown to a group of nurses and doctors, only 50% of seizures were correctly identified. And 80% of the non-seizure events were incorrectly identified as seizure as well. So that means there is both underdiagnosis as well as overdiagnosis. It's very common when it comes to neonatal seizures. So EEG is a mandatory to diagnose a seizure. To confirm the seizure, you have to do an EEG. And in fact, the gold standard test is a 24-hour video EEG, which is not easily available in most of the units at bedside. And one caveat is that not all epileptic events are identifiable in surface EEG, because we are using limited EEG, especially amplitude integrated EEG. So most of the seizures will not be picked up in EEG. That is also an important thing. So why do you want to identify seizures early? Seizures are harmful to the immature brain and can result in adverse long-term neurodevelopmental outcomes. So any prolonged seizures can cause neurological injury, can cause neuronal damage, cell death, and can cause neurodevelopmental impairment. And on the other hand, unnecessary treatment with anticonvulsant drugs can also have unwanted effects on the developing brain, because many anticonvulsants are neurotoxic, and that is also should be borne in mind. So you have to correctly identify the seizure. Now, moving on to the types of seizures. This is the classification by Volpe. It's a simple classification. There are 4 types. Here it is clonic seizures, tonic seizures, myoclonic, and subtle seizures. And clonic is again divided into focal clonic, multifocal clonic, and generalized clonic. Tonic is again divided into focal and generalized. Myoclonic is again focal, multifocal, and generalized. So these are the main 4 types of seizure. When you find a true seizure, when you find a seizure, you have to identify and assign the type of seizure. You should document the type of seizure as well. Now, coming to the clonic seizures. It's a very common condition, very common seizure. Here, there is a rhythmic movements of the muscle groups. And the most important thing is you can see the rapid and slow phases. Like you can see here, here's a baby throwing seizures. And if you concentrate on the right upper limb, you can see the clonic movement. There is a fast component and there is a slow component. And it cannot be suppressed with gentle pressure. And there is usually a consistent EEG association. And usually the focal seizures have a favorable outcome. And the usual etiological factors are perinatal strokes and metabolic encephalopathies, especially the hyperglycemic encephalopathy. Hyperglycemia can cause focal seizures rather than generalized seizures. And in multifocal clonic, another condition is the multifocal clonic seizures. Here, the several body parts are involved. And you can see here, the left lower limb as well as the left upper limbs are involved. And usually they are non-synchronous. That is why it is called multifocal clonic seizures. And generalized clonic seizures are very unusual. They are symmetrical and synchronous, very, very unusual in newborn because of the brain maturity. So focal and multifocal seizures, clonic seizures are common. So this is a multifocal clonic seizure, this is a clonic seizure. Now, the tonic seizures. Tonic seizures could be either a focal seizure or it could be a generalized seizure. Here you can see there is a sustained flexion of the axial, the right upper limb. You can see the seizure and with the posturing of the tongue and neck. And this is classically the tonic seizures here. It's a focal tonic seizures. And here it is a generalized tonic seizures. And in fact, if you look at the EEG, generalized tonic seizures has less EEG changes. Only 50% can have a EEG abnormality. That means usually the generalized tonic seizures are non-epileptic. Yeah. So this is a you can see here the generalized tonic movement. All four limbs goes into a tonic spasm. This is a generalized tonic seizure. Okay. Now, the myoclonic seizures. Myoclonic seizures are sudden shock-like contraction of the muscle groups. Usually, the flexor muscle groups are involved. There are three variants. There are focal, multifocal, and generalized. And here it is rapid. And compared to the clonic seizures, the movement is very rapid. That is called shock-like contraction. And the slow component is usually absent. And it has got the worst prognosis, especially for a generalized myoclonic seizures. It's a very, very worst prognosis. And focal and multifocal seizures generally are not associated with EEG changes, but generalized myoclonic seizures are usually associated with EEG changes. You can see in the video, you can see this baby there are shock-like contractions in the multiple muscle groups, the upper limb, lower limb. Again, you can see the baby. Yes. And also, if you look at the face of the baby, you can see the tonic deviation of the eyes, which could be part of the subtle seizures, which we'll discuss in the next slide. Okay. In subtle seizures, actually, it's the commonest type of seizure that you see in newborn, and also it can be easily overlooked as well. And it most commonly seen in preterm babies. Doesn't mean that it is rare in term. And there are different types of subtle seizures are there. It can manifest as ocular phenomena in the form of staring spells, which is more common in preterm babies. It could be in the form of eye deviation or conjugate deviation of the eyes to the either side, which is more common in the term babies, or it could be in the form of blinking. Oral phenomena can be in the form of sucking, chewing, or lip smacking movements. And also you can have fragmentary body movements in the form of pedaling, cycling, and swimming in the lower extremities, or it could be a boxing movements or hooking movements of the upper extremities, which are very common. And it usually associated with autonomic phenomena like pallor, apnea, and salivation, heart rate or BP changes like that. And here, apnea is of special importance because apnea can be a manifestation of seizure. It could be in preterms, it could be a manifestation of immaturity. But most of the apnea what is seen in newborn, in preterm babies are due to, not due to seizures. And one important identifying feature in apnea is apnea usually associated with bradycardia, but in seizures associated with apnea, there will be either tachycardia or normal heart rate. That is the differentiating point. And EEG changes are less likely in subtle seizures because it usually represents a brainstem release phenomena. Okay, you can see the face, you can see the eyes here, you can see the conjugate deviation of the eyes to the and actually the subtle seizures usually associated with other types of seizures as well. Okay. Now, what are the common seizure mimics? There are common mimics as and not so common mimics also. So the common seizure mimics, the conditions which can mimic seizures are jitteriness, benign neonatal sleep myoclonus, Sandifer syndrome, and other tremors and myoclonuses. So not so common conditions are dystonia, dyskinesia, hyperekplexia, and drug reactions. So the most important one to differentiate from jitteriness is from seizure is jitteriness. Jitteriness is basically tremor-like movements. which has got equal rate and amplitude unlike clonus. And there is no ocular phenomena. Ocular movements are normal. Here you can see the sudden startle-like reaction. It's a tremor-like movements. It is not clonus because equal amplitude and equal rate. No ocular phenomena. It is actually stimulus sensitive. You can see after the stimulus, it becomes exacerbated. And usually it can be abolished by gentle passive flexion of the extremities, and there will not be any autonomic changes, and the EEG will be essentially normal. And usually it is seen in IDM babies, diabetic mothers, infants of diabetic mothers, following perinatal asphyxia, hypoglycemia, and hypercalcemia. So that is jitteriness. It is essentially to differentiate from myoclonic seizures. And the second condition is also very common. It's a benign neonatal sleep myoclonus. You can see the sudden shock-like contractions in the sleep, and is present only during sleep. That is the differentiating point, and is usually abolished by waking up the child. It can last for minutes and usually exacerbated by benzodiazepines, and is usually resolved by around 2 months of life. This is also very common. Benign neonatal sleep myoclonus also should be differentiated from myoclonic seizures. The third conditions which you should remember is a Sandifer syndrome. Sandifer syndrome is basically the spells of opistotonic posturing and stiffening with staring and jerking of extremities rarely, and usually associated with GER, and is supposed to be due to the pain from the acid reflux into the esophagus. And it's usually typically occurs within 30 minutes after a feed. Okay, there is the arching of the baby, and there is extension of the extremities, and lasts for around few seconds to minutes. Okay, so again, it is a common condition, and I should differentiate from a tonic seizure. Neonatal dystonia, dyskinesias are rare. These are movements which can be, these are pathological, obviously it is pathological, but they are not true seizures. Can be there in asphyxia, metabolic disease, and maternal drug toxicity. And prokinetic drugs like domperidone, metoclopramide can cause neonatal dystonic movements. Hyperekplexia is a different entity. It is also known as startle disease or a Stiffman syndrome or congenital Stiffman syndrome. Here you can see a hyper-alert baby with exaggerated startle and tonic spasms, usually in response to stimulus like auditory, visual, or kinesthetic stimulus. And this condition can present even in utero as well. So it can mimic seizures, intrauterine seizures. The tonic spasms can result in death also. And it's a genetic condition which is caused due to a glycine receptor mutation, which can be transmitted autosomal dominant, and usually disappear by 2 years. It can be major, it can be minor. Usually minor variant can disappear by around 2 years. So that's about the seizure mimics. The carry home messages are the newborn, as you know, newborn can present with variety of abnormal movements, and clinical identification of seizures is a difficult task, of course. And underdiagnosis and overdiagnosis of seizures are very common. And EEG is the gold standard for the diagnosis of seizures. And it is important to identify seizures and treat early so that damage to the brain can be minimized. Thank you for your patient listening. And that's all. Thank you.